Caffeine can exacerbate seizures.
It can. So there are a lot of things, again, for everybody, things can be different.
Apparently this is very common. Up to 200,000 kids in the United States are diagnosed every year. Is it that many?
Yes, there are that many. Actually, in the Missouri public school system, there are at least 7,000 children that have epilepsy.
Oh my goodness.
Yeah.
Hi, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My returning guest today is Dr. Komal Ashraf. Welcome back to the show, Komal.
Thanks, Gil. Happy to be here.
Dr. Ashraf is an assistant professor of neurology. She's board certified in neurology and psychiatry. It's the same board. And in addition to being an expert in concussion and all things neurology, you're also an epileptologist.
I am. Thank you, Gil. Yeah, that was very generous. I'm not an expert in all things neurology. My really subspecialty areas of focus are concussion, as I was here before for that, and epilepsy. So somebody who's done fellowship in EEG and epilepsy is an epileptologist.
Gotcha. Now, an EEG is an electroencephalogram, I believe.
Yes.
And it involves putting little electrodes. Is it a dozen of them on the head or so? How many are there?
Yeah, so on the scalp, there are 20.
20.
And just like an EKG where we put stickies on the chest to
About
monitor.
12 of them around the heart.
Right, to monitor and measure the electrical activity of the heart. We can put stickies on the head, as you said, and monitor electrical activity of the brain. And you'd be very happy to know that I did my subspecialty training at Michigan.
You've written Go Blue.
Go Blue.
Love it. Love it. That's fantastic. So I've seen the readouts from these EEGs, and it is just squiggly lines all over the place. And it takes a long time to be able to learn about interpreting them. But they tell you about the workings of the brain deep inside and the electrical workings, right?
Yeah, it's my favorite thing to teach, actually, the skill and the art of reading an EEG. It's really fun to watch my learners think about them as squiggly lines and then to actually be able to make sense of them by the end of our time together. So, yeah, we see different patterns on the electrical activity based on wakefulness, drowsiness, sleep. We can check symmetry, synchrony of the left and right hemispheres of the brain. And we can see degrees of slowing or encephalopathy. So oftentimes studies are gotten for confusion just to see how quickly the brain and normally the brain is functioning. And then we can see seizure activity as well.
Fantastic. Oh, that sounds very exciting. Sounds like it's a never-ending learning process.
It is a fun skill to have.
Now, we're going to talk about epilepsy today. So let's start at the beginning. I believe epilepsy is a condition where a person has recurrent seizures. So let's start at the beginning. What is a seizure? Help us understand that, please.
Yeah, so a seizure, what I like to tell my patients, is an electrical storm of the brain. And two or more that are unprovoked would be considered epilepsy.
So let's get to the basic functioning of the brain. It's these neurons, these cells that have a body and generally have a long tail, right? Called an axon, right? And there's connections all over, and these can connect with other nerve cells many different ways. And it's almost an infinite number of combinations if you multiply all the combinations. The numbers are just astronomical. And these neurons fire, right? They send off a potential and a wave goes down this axon. And normally, like you and me right now, what is happening to our neurons right now? What is the normal state of the brain?
Yeah, so I'm awake right now. So I have a normal, I assume normal posterior dominant rhythm, which is defined by EEG, but it demonstrates a normal wakeful state. And if I was to fall asleep, I would have a pattern that's consistent with a drowsiness or a deeper stage of sleep. But right now, just being awake, you're making me use my brain. So I suspect that if I had an imaging study, maybe my temporal lobes would be firing. Maybe my frontal lobes would be firing. So epilepsy.
Yeah, but the firing of a normal brain.
Sure.
Help me here. It's more predictable. There's normal rhythms. There's normal coordination between areas. Like, what is a normal firing of a neuron versus an abnormal firing? I guess is what I want you to try to explain to me.
Yeah. So in the awake state, we would see that neurons are firing at least in the posterior part of the brain. According to alpha frequencies. So frequency is a cycle per second.
Okay.
And so on an EEG study, we read how many cycles in 1 second. And in the awake state, we expect alpha frequencies, or 8.5 to 13 hertz.
Okay.
And in the drowsy state, we see slowing compared to the usual alpha frequencies. And then in the asleep state, depending on what stage of sleep, we see different other sleep architecture, vertex waves, K complexes, sleep spindles, and then further slowing.
Okay, so we have this normal firing. I don't want to belabor this too much, but I want to try to understand what is different about the firing of these neurons during a seizure. What's happening?
So in a seizure, I like to think of and explain it as just one rogue neuron or a network of neurons that have hyperexcitability or fire more than they are supposed to.
Okay.
And so this is different than a stroke, for example, where you have less firing or dying of neurons. Here you have a revved up of neurons. And so that's what that electrical storm is. And so a seizure electrographically on the EEG is a rhythmic electrical storm. So it can start with the whole brain, all the neurons synchronously misfiring at one time. That's generalized epilepsy or generalized seizure. Or it could start from one rogue neuron or small network or space or area of the brain that then revs up, and then spreads. And we can see that electrographically. There's different criteria that we use to call a seizure just based on the EEG.
Okay.
But then outwardly, people experience different things too.
So we've got the normal state of health. Neurons are firing in their normal rhythm in a coordinated fashion. Everything's working together. But something can fire up a neuron or a cluster of neurons to start firing more often and maybe higher amplitude or something?
Yeah, so we have different criteria on EEG for just talking solely about EEG.
Okay.
There's usually a positive and negative mismatch, or a bipolar montage where we can see a polarity. We can see positive polarity and negative polarity. And that is an opportunity for an electrical storm. And so that is what we would call an epileptiform discharge, where we would see a spike or a sharp wave that would be kind of a misfiring of an electron or a cluster of them.
Okay.
And then that pattern will evolve. It will become either more frequent. Usually the pattern is acceleration, then deceleration. We might see spread topographically, so spread to involve other areas of the brain. And we might end up seeing a change in morphology of the rhythm, so a change in the actual waveform. So 2 out of 3 of those criteria that last at least 10 seconds based on EEG would be a seizure if it starts in one area of the brain.
Okay.
Then it doesn't really matter how long an electrical pattern lasts on EEG if a person has an outward manifestation or a phenotype. It has something happen to them that is abrupt and might just be what we would call a stereotyped spell.
All right. So let's talk about that.
Sure.
So now I've got a better idea. These cells go rogue. They create a storm of activity. But outwardly, there's some typical appearances. So let's say we have a parent. And they're with their child. Child has been in otherwise good health, and all of a sudden, some scary things start happening. This isn't normal. What are the things a parent might recognize in a child that suggests, oh, little Johnny, little Jane's having a seizure? What kinds of things do you look for? Do you see?
Yeah, so that's a great question, and it's not the same for everybody.
Okay.
But in kids, the most common kinds of seizures would be a few different types. We have myoclonic jerk type seizures, so jerking, shaking, twitching, flinching.
Just out of the blue, for no real reason. They're not swatting at flies. It's just all of a sudden out of nowhere.
Yeah, and that can typically happen when people are sleep deprived or early in the morning. We can also see generalized convulsions. And by the way, all of these seizure types can end up becoming the things that you see in movies. Whole body convulsions, tonic-clonic jerking. Yeah.
Okay.
But then you can also have staring off spells or eye fluttering, oral motor automatism. So something just as subtle as that, or it can just be a behavioral arrest episode where I stopped usual speaking, my intonation changed, or I just didn't do anything, or kind of purposeless movements, just maybe staring off and doing some purposeless movements, picking at things in the air. Those are things that can be specific for different types of seizures too.
So it might not be so obvious, but if you're paying attention, there's something different.
Absolutely. So in my opinion, and I've seen this happen and be missed, is for kids that are labeled or diagnosed with ADD, ADHD, which is prevalent.
Right.
All of those kiddos should probably have an EEG at some point. I've unfortunately seen a kid who's been diagnosed as ADD, ADHD on medication for many, many years, waxing and waning effectiveness, maybe based on their age and development and maturity and things like that, or are they doing what they like to do, so they're focusing more. But so you see sometimes waxing and waning, and then years later, they might get an EEG because they have actually evolved into tonic-clonic jerking, or the medication stopped working. And so then we get an EEG and we see a typical epileptic pattern.
Misdiagnosed.
Yeah.
Now, will the medicines for attention deficit disorder and hyperactivity disorder, they're usually fairly stimulant.
They are.
Would that make a seizure even worse, maybe?
Doesn't have to.
Caffeine can exacerbate seizures.
It can. So there are a lot of things, again, for everybody, things can be different. So some people, are extremely sensitive to sleep deprivation. Some people are extremely sensitive to flashing lights. Some people even hyperventilation. Very common pediatric epilepsy syndromes are very sensitive to hyperventilation.
Now, is that from anxiety or just from exercise? Or
I don't really think the mechanism is known for how, but we often hear kids after PE class when they've been exercising, they'll zone out, have that little eye fluttering, and it will be noticed after PE class, whereas at home, they might just be hanging out, chill, not really hyperventilating for any reason.
Right.
And so it's not really picked up at home, but it's picked up at school.
Okay, so to summarize this, if it was in a child, they would do something new, maybe zone out a little bit, but it doesn't have to be a frank generalized seizure to suggest that there might be some type of epilepsy or some type of seizure activity going on. Very interesting. Apparently, this is very common. Up to 200,000 kids in the United States are diagnosed every year. Is it that many?
Yes, there are that many. Actually, in the Missouri public school system, there are at least 7,000 children that have epilepsy.
Oh, my goodness.
Yeah.
And I've heard perhaps, I mean, our country is about 340 million, about 1%, 3.4 million. I've just read people in this country, that's 1%, have epilepsy, this recurrent seizure disorder.
Yes. Yeah.
Wow.
It's much more common than we think.
Wow. So is it usually recognized in children, or can epilepsy come on later in life?
Yeah, so epilepsy has this bimodal distribution. So we see that it's very commonly diagnosed for the first time in kids. And then there's a couple decades of age where we don't really have a lot of new diagnosis of epilepsy, but it can happen, of course.
Okay.
And then in by the older population as well. So over 55, 60, that we might see an occurrence of new diagnosis of epilepsy as well.
Interesting.
And in that population, we think of more focal onset epilepsies. So the brain has had time to develop wear and tear and scar tissue and different structural changes. Could be stroke, could be trauma, could be concussion, could be brain tumors. Could be brain tumors or strokes, or all of these different type of insults to the brain can accumulate and be a source for epilepsy, which would be then focal onset. So where the location of the structural change is, we see that rogue network of neurons getting hyperexcitable and firing, and then this electrical storm. But the key is stereotyped spells. So even in kids, we see typically that based on whatever type of epilepsy they have, it's manifested in a similar way every time that they have a spell.
So the spells are typical for that person. That person will have the same type of spell over and over.
Yeah.
I see. Now, I noticed some of the names for these spells are French in origin.
They are.
Was a lot of the first doctors that researched this, were they in France? Were they French?
Well, a lot of neurology is based out of France, and the grandfathers of the grandfathers are French. So we have seizures that start in an area of the brain, the temporal lobes, that would be manifested by déjà vu or jamais vu.
Jamais vu. Déjà vu means you've already seen it, and jamais vu means you've never seen it.
Or the premonition of that spell.
Oh, the premonition.
Yeah,
Interesting.
yeah.
Jamais vu. Love it. Love it. So that's temporal from this area here.
Yes.
Now, what is petit mal? That means small bad. What is a petit mal seizure?
Yeah, so some of this is old nomenclature versus new nomenclature. So, the old nomenclature would be grand mal or big bad.
Big bad, yeah.
And
grand
then,
mal.
yes, and then there's petit mal or small bad.
Small bad.
So petit mal seizures are what we now call absence or behavioral arrest. So some of this is a little bit nuanced, but when diagnosed in kids, the outward appearance of behavioral arrest, meaning stopping their activity, staring off potentially, sometimes these purposeless movements, sometimes oral lip smacking or fluttering, if that is time locked or matched with a very specific EEG pattern of a 3 hertz spike and wave that's generalized, that is diagnostic of absence epilepsy.
So you'd have to catch it. You'd have to have the EEG in place. They'd have to exhibit that behavior, and then you could match them.
Absolutely, yes. So the gold standard is having someone on EEG, time-locked event with the electrographic study going on at the same time to characterize it.
Gotcha.
And so an absence seizure is what was previously known as a petit mal.
Okay, so that's the preferred name now.
Yes, and then grand mal, the big bad, is now what's known as a generalized convulsive or generalized tonic-clonic seizure.
Okay, so convulsions are Tonic means firm or tight, right?
Stiff.
And clonic, stiff.
Yeah, so
and
that
clonic means
jerky.
jerky,
Exactly.
right? So stiff and jerky.
Right.
And I've got to ask this. If somebody's having a tonic-clonic, are you supposed to put something in their mouth to keep them from swallowing their tongue? Does that happen?
No, thank you for asking that.
I had to ask.
Yeah, so seizure safety is actually really important that we try to counsel people about because of these misconceived safety things. No, you absolutely don't stick anything in someone's mouth. Someone is super tight, they could bite off whatever you put in their mouth, whether it's a tongue depressor, your finger, a tablet, something, and then they could aspirate it.
And
or
break
you could
their teeth, right?
Break their teeth, you lose a finger, it's just bad.
It's
all
bad.
around the wall.
Stay out of there.
Yeah, and for sure. So similarly, sometimes we can see this really clenched, the whole body is clenched essentially. And so that is that tonic phase.
Gotcha. So while we're on it, let's just finish the thought. Is there anything, so if you witness somebody seizing, what if you're a bystander, if you're a good Samaritan, what are you supposed to do?
Yeah, so great question. Making sure that their environment is safe. So making sure that if this happens at the gym, trying to make sure that weights are away from their head or that they are, not going to continuously bang their head on something or tear a ligament or injure a joint or injure themselves if it becomes a more violent type of seizure where there's convulsions.
Okay.
So making sure that someone's environment is safe.
Can this happen in the pool? Can you keep somebody from drowning?
It can. So part of our seizure safety discussion is if somebody's had a seizure to wear a life jacket and make sure that there's a lifeguard to be able to, rescue somebody.
Right.
Prefer not open water. I also counsel, especially here where we have quite a bit of a hunting population, to not go out super early in the morning or late at night, to avoid being in a tree hut and to go with somebody who you really trust. Here also where we have, different weapon laws to make sure that if someone has a concealed carry license that they don't have a weapon on their person 6 months after a seizure or an unexplained loss of awareness. God forbid this happens in public. They could be disarmed with their weapon taken from them. So if someone's a biking person, they ask them to wear a helmet. Someone takes baths and can fit in a bathtub, then make sure that the door is cracked, that they communicate that they're taking a bath so that somebody can check on them. And then if somebody goes for a walk or a hike outside, to really just communicate, which is the huge thing, is just allow somebody the opportunity to anticipate when they'll be back. Now, I know that sounds really limiting, but our goal as epileptologists is to help somebody be seizure-free, side effect-free of whatever the treatment option they choose. And truly, we have people that are able to return to their normal quality of life and activities. And here, none of those things are laws. In many states, there are laws. Missouri is not a reported state, but it's really the ownership of every person to make sure that they are as safe as they can be, and anybody who's with them. So driving being a big one.
All right. So let's say a parent witnesses one of these spells or something's wrong with their child. What's the next step they should take?
Yeah, so a lot of people start with their family doctor or their general practitioner. And I love epilepsy because to me it's the quintessential puzzling. You get a very good history. You ask a person long enough, or you talk to a person long enough, they'll tell you what they have. So you ask about the spell in detail, the what happened before, what happens during, what happens after, from head to toe. What does the event look like? How long does it last? How often is it happening? And then we get imaging. So we get to see the structure of the brain.
What kind of imaging?
So
X-rays, CAT scan, MRI. What are you talking about?
yeah, it depends on the age and really of the patient and who's ordering it. If you have a neonate,
Baby.
a little tiny baby who might be premature or doesn't have to be, who's starting to have seizures, then we'd probably start with an ultrasound of the brain. But I commonly get MRIs because it gives me the kind of detail that I need to see some of those rogue networks of cells or even areas. Here at the University of Missouri, we have a 7 Tesla MRI, which not many places around the country have a 7 Tesla.
Is that a powerful one?
It's a super duper powerful MRI.
Does that mean it goes faster?
Unfortunately, not faster, but we can see a lot more visual spatial.
More detail.
More detail, yeah.
Okay.
But an MRI is pretty standard. CAT scans, it would be like the quick and dirty. Say somebody has a new onset seizure, they go to the emergency room. The first study that they're probably going to get for imaging is a CAT scan.
And they're getting pretty quick.
Yeah, they are. And they want to make sure that there isn't anything like emergent, like blood collection in the brain.
Tumors, something,
that they can see, yeah.
Right. Now, the MRI, how long is one in the tube or in the ring for an MRI of the brain?
Yeah, so probably about 30 minutes to 45 minutes. And then the best way to visualize structure would be with contrast. So you get an IV with contrast, and then you get the images without too. So it gives us an idea of different structural lesions that might be there.
So it might be hard for a child to do that. What do you do in a child? Is there like an age cutoff, or you have to evaluate them with like one kid's particularly mature and cooperative?
Yeah, so we talk to parents about that quite a bit. So I have a 7-year-old and a 9-year-old. I think with some really a lot of hovering and pep talking, my 7-year-old would be able to do it. My 9-year-old, no problem.
Gotcha.
So I think it depends on the kid for sure. And it depends a lot on your preclinical suspicion. Mm-hmm. If you want to put a child through something like that. If your suspicion is really high and you really need to get a picture of the brain, then you can do it with sedation too. So have anesthesiologists and general anesthesia to help a child tolerate an MRI.
So you can do an MRI when a kid is sedated?
Yes.
You sometimes have to do that.
Yep. As opposed to an EEG, where you can't sedate because that messes with the brain waves.
Well, that makes a lot of sense.
Yeah.
So you can't suppress the brain.
Right. So the third piece, so now you have like the clinical piece.
Okay.
Then you have the imaging. And then you get the electrographic study. And that gives us the best kind of short of Superman type eyes of what is happening at the brain level when someone's having a spell. And the electrographic study gives us the electrical information. And so that, as we said, we hook people up. But we can hook people up for 30 minutes up to 7 days.
7 days?
To record their events, yeah.
Yeah, because I can imagine if they're not having the spell or the seizure while the electrodes are on, you're not going to see it. Yeah,
so it depends on how often the events are happening, as you said, and then also it depends on whether somebody's on seizure medication already. To really see the brainwaves in its truest form without the filter of medications or treatments, sometimes we need to bring somebody into the hospital electively, make sure insurance covers it, which typically they do.
Right. That, yeah.
And then we would wean off seizure medication and it's the safest place to do it because we're taking away potentially a treatment. Mm-hmm. There's redundancy in how and who's looking at the recording and with the video. So if I start shaking this, arm, I could have the EEG, somebody is monitoring. That way I make sure I'm not falling out of bed or going to the bathroom off of seizure medication. And then we can get an idea of where the electrographic event starts.
So you have, go ahead.
Or if, say, I do stare off, and there are a lot of reasons a person could have a spell, right? People could have heart problems that then are stereotyped spells, or endocrine or hormonal issues that flushing or sweating. They don't know what they are. Or at night, some hypermotor activity when they're trying to sleep. Could be REM behavior disorder, or it could be epilepsy. Or, someone could have a psychiatric condition where they have these like outbursts of behavioral changes, or someone could have memory loss or be on a medication. So there are a lot of reasons people could have spells. If you get an EEG, record one of their typical spells without a seizure pattern seen on the EEG at the same time, then you have now diagnosed that event that person is having that's stereotyped or appears stereotyped isn't actually an epileptic seizure. So it can be a very powerful tool.
All right. So now you've done the EEG. You've got an idea now. So what are the types of, does it matter on the location in the brain to diagnose it? What are the various types? I assume there's different types of epilepsy.
There are, and seizures, or those rogue neurons, can be basically anywhere, except usually we don't see seizures starting from the brainstem.
The brainstem from deep down in here. It's usually from out here, the cortex.
And potentially there's newer evidence that maybe deeper structures, even like the thalamus, we could see seizure activity either going through or starting at.
Okay, the thalamus is kind of midway through. It's where everything's connected. Lots of pathways or lots of highways to the thalamus.
Yes.
Yeah. I remember something from medical school.
That's great.
Wow. So you have found, so let's say with the EEG, you have found the location. You found the stereotypical waves that you're looking for. Now, how do you go about treating it?
Yes. So this is very, very exciting right now, because the tools that we have to treat seizures has evolved considerably, even since I've been in practice, which has been 10 years.
10 years.
So there are a lot more tools that we have. So we, of course, have medications. We have medications that are more generalized, or ideal for generalized type epilepsy. We have medications that are more focal for focal onset epilepsy, so seizure activity starting in one part of the brain. And we have kind of broad spectrum medications too, anywhere from generalized to focal. So medications is one. We have surgical options, like taking out the area of the brain that's causing problems. We have device options as well, so anywhere from same-day surgeries that's outside of the brain with electrodes to the vagus nerve, to deep brain stimulators that's put in, just like we've done for Parkinson's for many years, but really for epilepsy now. We have also the responsive neurostimulator, where we go through a process of identifying exactly where the seizures are starting from.
Okay.
But if it's in what we would call eloquent cortex, or an area of the brain that's in charge of motor, memory, language, taking that area out would affect somebody's quality of life.
Yeah.
Then we have the ability to put a device embedded in the skull right above the seizure focus to try to mitigate and de-escalate a seizure from happening.
So it starts and then this thing will fire up then. So you're not cutting out the piano lessons.
Right, that's right. And then we also have, more homeopathic type options, things like cannabis, and ketogenic diets.
Yes,
specific
I've heard about that.
Lifestyle type things. And these are really options, kind of everything outside of medication is really options for what we call medically refractory people with epilepsy. So difficult to control epilepsy that has been very stubborn when using the more standard medication options or standard treatments such as medications.
In the old days, it was phenobarb, which is a barbiturate, which is a downer.
Yeah.
Right? Very nonspecific, kind of turns everything down, right?
I don't think I've ever started phenobarb.
So part of that shows you how old I am. Then there was Dilantin, diltiazem, I think.
Yeah, phenytoin. Diltiazem.
No, that's a calcium
benzo.
block. Yeah. Oh, diltiazem.
Diltiazem is the calcium channel.
It's a calcium
Yes,
blocker.
yes.
Yeah.
Diazepam is
Diazepam is the benzo.
Yeah.
And so Dilantin, does anybody ever use that anymore?
Not often, just because there are some really bad pharmacokinetics with other medications that when the key about seizure treatment is, and what I think of when I think of medically refractory epilepsy, is the chipper of all chippers. Like a chipper being a hard workout that you just keep chipping away at, a long, hard workout.
Yeah.
And pivoting, making choices on how you're going to break up a set or something to get it done. So, the medically refractory epilepsy is kind of like that, the chipper of all chippers. So we might have to have layered approaches, medication, lifestyle changes. So some of my patients have catamenial epilepsy.
That means during their menses.
Yeah. So they end up being on a birth control mechanism, medication that might really help to decrease their number of seizures.
Yeah, just keep their estrogen at a decent level all the time.
Yeah, that's right.
At a decent, yeah.
Or some people that are photosensitive or sensitive to flashing lights, we might say, make sure you're wearing sunglasses all the time. Some people have, spells that are provoked by, just sleep deprivation. So we make sure that their sleep is really, really well managed. So it's the chipper of all chippers.
We mean to take it a little one piece at a time and progressively just keep adding on and finding what finally gets you through it.
With the goal of seizure-free, side effect-free, and optimizing quality of life. And so, if the standard first step is medication, and we try to make sure we're thoughtfully choosing not just phenobarb for everybody or Dilantin or Depakote for everybody, definitely not Keppra for everybody, which is the number one prescribed kind of knee-jerk response for epilepsy.
So Keppra is a common medication.
It is.
And that came out, I don't know, 5-10 years ago. It's not that old,
1980s.
1980s it came out?
Yeah, already.
Oh boy, I'm telling my age. I know Keppra because it's fairly safe in pregnancy.
It is, but many of these are now safe in pregnancy. But Keppra or levetiracetam, lacosamide or Vimpat, oxcarbazepine, trileptal. I actually did a case report on the use of cenobamate or Xcopri. This was just a case report on a patient that delivered a healthy baby on Xcopri. So there are many more medications now. Lamotrigine, super safe in pregnancy.
Yes.
Yeah.
Lamictal.
Yes. So we try to thoughtfully start a person on a seizure medication for prevention based on the type of epilepsy a person has, their lifestyle, and other comorbidities, right? So
that means other medical problems.
Right. So if somebody has, for example, underlying depression, anxiety, Keppra might not be a very good choice for them. Someone who has, heart block or cardiac issues, maybe lacosamide or Vimpat isn't a great option.
It's not.
Right. And we see, for example, today's Memorial Day, so we have our veteran population sometimes experiencing post-traumatic epilepsy where they've sustained a blast injury or something like that. But they also might have PTSD or might have sleep issues. We don't want to start a medication that's going to exacerbate any of their underlying medical issues. And then, so that's preventative. And then it's really, really important to try to consider whether somebody needs a rescue medication or an abortive medication.
almost like asthma. You got a rescue inhaler. It's really you're taking your meds every day, but sometimes you get an attack and you've got your puffer or whatnot for the bad days.
Right, an EpiPen, just like EpiPen or
for an allergic reaction.
That's right. So we have now rescue options.
I didn't know that.
Not, so I think it's really important to consider the newer options because one of the oldest is they're all benzodiazepines because they work the fastest. And
like Valium or Librium would be the granddaddy medicine in that category.
So we have nasal spray options. So nasal diazepam and midazolam, nasal spray midazolam as well. As opposed to rectal diazepam, because who would
who's
want
going
that?
to do that? Right. Could
the chances of that being not video, social media,
ain't happening. So you can have a benzo nasal spray that gets in really quickly.
Yes, and it prevents people from having to come to the hospital. So we have data that it's reduced hospital utilization costs. It's improved quality of life. It's like a good insurance policy that every caregiver wants something to be able to do to help. It shortens the seizure duration, prevents clustering, and returns someone back to their usual state quickly compared to not. They don't have to.
And if they've got experience with it, hey, midazolam, is that Versed?
Yes.
It's Versed. So you can take a little nasal spray and in a couple hours maybe get back to their normal state of health.
Yep.
Don't have to go to the hospital, which is very, very expensive. Now, I read somewhere that about 70% of epilepsy cases can be treated medically successfully. Does that sound about right to you? It seemed a little low, but...
Yeah, so unfortunately, we know that despite all of these new medication tools, there's about 60% of patients that are going to require multiple medications that might end up being seizure-free. And seizure-free is a very concrete definition of 12 months of no seizures.
Okay.
And so, and oftentimes these people need layering on of medication. We know that probably about 30% of the time we start the first medication and someone becomes seizure-free. So that's only 30% of the time.
So almost a third of the time, start a med, did a great job. Everybody's happy.
Yep. But the other times, sometimes that layered medication approach is necessary. Okay. And sometimes then if someone has tried and failed 2 or 3 seizure medications, then and they're still having the problem, they're still having seizures, then we might need to consider other things like vagus nerve stimulator as probably the least invasive.
Now, who does that? Does a neurosurgeon do that?
Yeah.
Or do you do that as a neurologist?
No, I just program them on a monthly basis after interrogate them after they've been placed. But neurosurgery or cardiothoracic surgery usually puts them in.
So CT surgeons can also do that sometimes?
Yeah.
Okay. Where in the vagus nerve do you hook it in?
Right about, pretty distally.
Here in the neck?
In the neck.
And does it go next to it? Is it a pad or does it go around it?
Around it.
It goes around the vagus nerve.
Yeah.
And you can stimulate that with a device here. And I'm sure you have some kind of little box that goes outside. You said you can interrogate it, which means question it. And
they have a wand.
Okay.
So when they come into the office to get programmed, patient holds up a wand. I have what looks like a tablet, and then I look at the current in milliamps that's being delivered, the frequency of that current. And this is very small amounts of current. It's not like anything that's like a black cat that makes someone go or anything like that. It's basic. Most people don't even feel it.
Okay.
And then we look at frequency. We look at pulse width. So it's not one continuous pulse. It's short bursts of pulse that are in microseconds within a cycle. And then on time, so how long is the duration of firing? So 30 seconds at a time usually is the standard setting. And then there's an off time or up to 5 minutes. So then over time, we can program the device from as low as 0.125 milliamps all the way up to 3.5 milliamps. And then frequency goes from 15 hertz all the way up to 35. Pulse width goes, so there's a big range. So it becomes a very powerful tool.
And your experience, and this is where a board certified, and I also want to point out that you said you're not a psychiatrist, but you're board certified in neurology and psychiatry because these medicines can have cross-reactive, can affect psychiatric issues, depression, mood, etc. So they're all connected, aren't they?
Very much connected. So our frontal lobes house a lot of our emotions.
Right.
And so because of the neuropsychiatric type medications, we have to understand the whole axis. Yeah.
You certainly have to do it. And in interpreting the results of these stimulators, you need to know what your options are. What are you going to do? How do you follow it? I'm sure that's something that only comes with a lot of experience.
Yeah. So, the VNS has been out for a really long time. One of the
Vagus
things
nerve stimulator.
The vagus nerve stimulator. One thing that I really, appreciate about it is the sense of control that a patient and caregiver has with it. So it has shown to improve quality of life because it looks just like an Apple Watch. Patients also get what looks like a little black watch that if they feel a seizure coming on, they can swipe it and it delivers an extra current that I've programmed or an epileptologist has programmed to be a slightly higher setting to try to abort or make a seizure stop. So that might be the first thing someone does. Then if they have a seizure, maybe use the nasal spray. So, for example, people that have that menses-related seizures, I might say, hey, if it's a day that you expect to have seizures because you're cycling, give yourself 3 or 4 extra swipes. It's not going to hurt anything.
Gotcha.
And 95 to 99% of people that have a VNS get the battery replaced when it's time for that. And that can last somewhere between 6 to 8 years.
Oh, wow. So they're good for a long time.
Yeah.
Wow.
Then there are 2 new devices, and that workup is a little bit harder, but that can lead to either taking a focus out or neurosurgery or a little like laser therapy or zapping of a scar tissue. So I mentioned, we match up the outward presentation of someone's seizures. For example, if that matches, someone has deja vu, we might think temporal lobe. If that matches with an MRI finding of, for example, mesial temporal sclerosis or focal cortical dysplasia or some finding on MRI.
These are lesions. These are abnormalities of the anatomy that you can pinpoint.
Right.
Okay.
Using an MRI or imaging. Then we see electrographic evidence that the seizure is starting from the same concordant place. So say everything is matched to the right temporal lobe. Then say somebody is right-handed. And we confirm that with neuropsychology testing and WADA testing. It's a procedure test that we check memory and language. And neuropsychology helps us to define function of different areas of the brain. Say we can place memory and language on the left side.
Away from it.
Okay. But everything seizure-wise is focused, is matching up, or what we call concordant, to the right temporal lobe. Then we have some options. We can either take out the temporal lobe.
Isn't that it? It sounds so scary to take a whole lobe out.
It does. But we have a wonderful team. This is not just one person's perspective. So we meet very regularly about cases like this, and it's 3 epileptologists, 2 neurosurgeons, neuroradiologists, neuropsychologists, our EEG tech, just a full team to review all the data on one person to make sure we're making the right recommendations.
Yeah.
So we take the lesion out. We could put in a device right over the area of the seizure.
Okay.
See if there are a few situations, a broad network of seizure activity happening, or it's they're having seizures from both hemispheres independently, right and left.
Boy.
Then we can put in a deep brain stimulator. Like I said, what people have had for Parkinson's for a long time, but now we're doing for epilepsy. And then both the device in the brain and the deep brain stimulator need programming. That requires a few extra middle steps, but like EEG from the surface of the brain or even deep sampling of the brain. So we do that.
Oh, wow. That sounds very high-tech and complex.
It can be.
Oh, boy.
We have a great team, though. So
you need a team. It's called a tertiary referral center where they got all the different subspecialists there who can have these conferences and team meetings about difficult cases.
Yeah. We record the seizures. We all review all the seizures. We review the imaging, all the pieces of the puzzle, and then figure out how best can we try to help with the tools that we have to make somebody as close to seizure-free as possible.
Boy, well, let me ask you a little bit about this then. How does one find a team? Is it called an epilepsy team? Is this something certified like a stroke center or a heart attack center or a trauma center? Or is this recorded? Can you Google this?
Yeah, so epilepsy has been a problem for people for a very, very long time. So even back to the Hippocrates time, there are early accounts of focal status epilepticus, or seizures that start from one place of the brain and just cluster and cluster and cluster, or go on for a long time. Mm-hmm. So from then till even now, we have primary doctors or family doctors even trying to manage people with epilepsy. And that is a coined term worldwide by the International League Against Epilepsy, is PWE, or people with epilepsy. And so it can be a variety of clinicians that try to treat patients with epilepsy. If it's one of the more challenging, kind of more stubborn types, or their side effect or medications, or you're not living your best life, you really should have a subspecialist view on the whole thing.
So we're lucky to have a team here in Columbia, Missouri.
Yeah.
How does somebody know if there's one in their neighborhood or in their city? Or
you can Google. Well, you can ask your primary doctor.
Okay.
Who do you recommend for difficult, epilepsy? But it's also a level 4 epilepsy center are the ones that have all the various types of EEG testing, neurology, epilepsy, neurosurgery, can place the devices, have neuropsychology, et cetera, et cetera. So a level 4 epilepsy center does all of the different testing.
Okay, that's good to know. It's good to know there's a resource out there for that. Wow. Now, is there anything else about epilepsy we haven't covered? You had mentioned the legal part of it. You don't want to be carrying a gun or something, having a seizure. Does it mean you can't be a pilot if a pilot gets epilepsy? Do they have to stop flying?
Yeah, so I think all of that is dependent on their licensing boards and their employers as well. Safety is always in some of those service fields. I take care of quite a few local servicemen and women, and I've cleared or I've had to excuse many military servicemen and women in the past. So, I think that every case is different. How long have they been seizure-free? How well are they tolerating medications? Are there side effects? What are their governing bodies looking for? What are their employers looking for? There's a lot of moving parts when it comes to things like that.
Yeah, it must be very complex, and you've got a lot of power over somebody's life, and sometimes, depending on what they do. Not easy decisions. Well, there's no field in medicine where there are easy decisions.
No.
It goes with the territory, doesn't it?
It does, yeah.
So while we're wrapping this up, Komal, do you see any continued advancements in the world of epilepsy? Where do you see this going in the next 5 or 10 years or throughout your upcoming career?
Yeah, I mean, already in the last 10, it's been incredible to see the growth of the field. New tools to treat, new tools to diagnose, new priority for quality of life, types of treatment focus, a more multidisciplinary approach to the treatment of people with epilepsy. Also considering now, how to help someone to thrive in a condition that is otherwise seems very, very limiting, and trying to understand the condition better. So that has been really exciting. A lot of the focus now is in treatment. So what kind of neuromodulation can be done to help people be seizure-free, side effect-free, and as focused on quality of life as possible. Neuromodulation meaning using stimulation, like those devices we talked about, to try to treat epilepsy. One of the cool things about that is that it allows the brain to relearn. We talked about a seizure being a rogue circuit or a rogue network. If we stop someone's seizures early enough, and unfortunately we don't do a good job in medicine stopping people's seizures early enough, we see people having bad or difficult to treat seizures for 20 years before we discuss surgical options. Mm-hmm. But if we do it early enough, we give brains an opportunity to re-network, rewire, relearn, so we're able to stop the progression of memory loss. So we're trying to understand what that looks like.
So there's plasticity.
There's plasticity.
And I assume if you get it in a younger child, there's more plasticity and more room for healing.
Absolutely. The earlier on in someone's refractory epilepsy we are, or epilepsy diagnosis to get them well controlled, the better off the brain is. We're also looking, biomarkers is a big thing. I'm getting more involved in DOD type research when it comes.
Biomarker, usually it's a blood test. Is there something
test
you can actually test for that's a marker? It's associated with this. And DOD is Department of Defense.
Right. So I'm working with a team that looks at biomarkers or the blood sampling out of Atlanta, and we're hopefully applying for a Department of Defense grant looking at post-traumatic epilepsy. So military people, blast injuries, and the risk for developing post-traumatic epilepsy.
That's why they'd be interested. There's concussions. There's these shock waves. That might be damaging their brains, and you might. Oh, it makes a lot of sense. I'm seeing it right now here as I'm figuring this out. You can actually maybe identify people who are at risk for epilepsy or seizures after this type of injury.
And using biomarkers, a lot of medicine is now going towards that precision medicine. So what fits what kind of person medication-wise best? So, maybe not that trial and error process of this medication, that medication, side effect, but really making it focused based on someone's own genetic markers or biomarkers.
I love it. Individualized medicine.
Mm-hmm. And then
incredible.
We're wanting to try to figure out, when we think about modulation, the stimulation, where is the best place to stimulate and what settings of the devices are best? Frequencies, the circumference or the diameter of the stimulation.
Of the treated area.
Is it more anterior thalamus, posterior thalamus, pulvinar? What area of the nucleus of the thalamus is best? Just lots and lots of different areas of research.
So a lot of room for improvement. So let me paraphrase for you. You see the treatment of epilepsy continuing to evolve and continuing to improve.
Absolutely.
Very exciting field to be in.
I think it is. I love it. So I think also one thing that we do well and is really important, I think patient-centered, because it is scary and there, as I've mentioned, so many different steps to navigate, is we now have, and I think most level 4 centers should have, an epilepsy program coordinator. So somebody who can hold a patient's hand, through the system and help navigate all of these different moving parts to try to get people diagnosed as accurately as possible, to develop a plan of care that's customized and centered around what their needs are.
Fantastic. Well, Komal, thank you so much for explaining epilepsy to us, explaining the various treatments, at least in general, that are available. And hopefully, if parents see this in their children, they'll be quicker to act, to get them to an expert, at least their family doctor, so that these evaluations can begin. And I think the numbers you're telling me are really calls for optimism that almost everybody can be helped with this condition.
It's one of my favorite reasons about being an epileptologist is I have tools that I can help try to improve somebody's seizures. Whereas some areas of neurology, unfortunately, because of their progressive nature, you're a little bit more limited. But in epilepsy, in this world, we can actually try to have a menu that's find the right fit for the right person.
Fantastic. Well, I've learned so much from you, Komal. And can we have you back to discuss more topics in neurology sometime in the future?
I would love to. Thank you.
What a wonderful interview. Wonderful seeing you. And thank you for your time today.
You too. Thank you.